first job as a brand new nurse in an ICU that I now call an awake and walking ICU. And when I was interviewing for that job, it was at LDS Hospital in Salt Lake City, Utah. It's a medical surgical ICU, very high acuity downtown Salt Lake City, Utah. And during that interview, the nurse manager asked me point blank, one of the very first questions was, would you be willing to walk patients that are intubated on ventilators? And I was so new, so naive, so novice that I smiled and shook my head and said, yes, absolutely. I'm all about that, but you're going to have to teach me everything. And I started to be immersed into that culture. I was learning a lot of things for the first time. And I assumed that having patients awake and even mobile, a lot of times walking on a ventilator, was normal. In that ICU, they treated this approach just as standard, routine, and even optional as giving an antibiotic. So I didn't know that this was so unique. And I define an awake and walking ICU as an ICU in which sedation is only given when there's an indication for sedation. So medications like what we give in the OR, propofol, midazolam, things like that, that cause patients to be comatose, that is only given when there is an actual need for it. That might be patients that are having seizures, patients that cannot keep their oxygen saturations adequate when they move. They might have swelling in the brain, things like that. There are times when it's unavoidable and it's necessary to save their lives, to put patients into a coma. Otherwise, patients are allowed to wake up, even right after intubation. So we really are careful about when we give that sedation. In awake and walking ICU, you only give it if there's a specific reason for it. When there is a reason for it, then we give the safest sedative at the lowest dose possible for the shortest duration possible. Patients are doing their highest level of mobility possible unless there's a reason that they cannot mobilize. And there's open family visitation. They don't have restrictions, and families don't have to leave at 7 o'clock at night as many ICUs currently have it. So again, for me, I thought this was normal critical care medicine. In that ICU, it was normal to allow patients to wake up right after intubation. Oftentimes, if we had an opportunity, we would prepare them. If they were on high levels of oxygen, but not on a ventilator yet, we would explain to them, you need a breathing tube, you need the support from the ventilator. We're going to let you wake up right afterward. What would you like to use to communicate? Would you like a pen and paper? Would you like to text? A lot of times they are able to see other patients walking around the unit, so they've already had an idea of what that looks like. We obviously involve the family as they come out of sedation. A lot of times they wake up as if it was a colonoscopy. Drowsy, but it's been a very short duration and a low amount of sedation used just for the procedure of putting that breathing tube in. And then quickly they're awake, they're able to utilize their coping mechanisms, acclimate to the endotracheal tube, and we get them mobilized as soon as possible, usually within 12 hours, depending on their status or what's going on. And we have them mobilizing. Now, when I explain this to ICU clinicians, a lot of times they'll say, well, your patients must not be sick. These must be more LTAC patients or not higher acuity. Now, this ICU had one of the highest acuity or the sickest COVID patients in the state of Utah throughout the pandemic. It had its own COVID ICU. And they maintained this approach throughout the pandemic of allowing patients to wake up shortly after intubation. They were awake, walking in their rooms, doing squats to stands, things like that, even while on the ventilator, unless they got to the point in which they couldn't keep their oxygen saturations up and they had to be prone and paralyzed. Then they would be deeply sedated. And so these are sick patients. They have a bone marrow transplant unit in the hospital. So you'll have lots of multi-organ failure, severe septic shock, very immunocompromised patients. It's a transfer center, so patients come from 5 states around in the region to this ICU when they are failing in those other hospitals. So these, again, are very sick patients. And yet this has been the practice for almost 30 years to be awake and mobile on the ventilator. So this is what a lot of my patients looked like. So again, I thought this was standard, normal critical care medicine. No one explained to me that this was a very unique approach. No one told me about medically induced comas and all the other ICUs. So after 2 years of practicing this way, enjoying having deep human connection with my patients, knowing what kind of music they like, knowing what kind of food they were looking forward to eating after they got extubated, even being able to prepare them and walk them through the dying process when survival was no longer an option. I was having really sacred experiences there, and I loved it. But I was at that point 26, looking for more experiences and wanted to go to bigger cities and things like that. So I left, but I was totally unprepared when I became a travel nurse to find that in every other ICU I worked in for the next 2 years, patients were automatically deeply sedated the second they were intubated on a ventilator for any reason. And the first time I went to a new ICU, I received my patient assignment, and my patient was intubated, and there's nothing about their diagnosis or level of sickness that could explain to me why they were comatose, why they were sedated into a coma. And so I asked my orienting nurse at the time, can I get sedation off? Can we get them up? And they looked at me totally shocked and honestly terrified and said, what? No, they're intubated, which didn't make sense to me because, again, I had seen so many patients be intubated or have a breathing tube and be awake. And so I innocently responded and said, I know that they're intubated, but why are they sedated? And she said, because they're intubated. And again, I just innocently kept responding, but why are they sedated? And we kept running circles around each other because we couldn't speak each other's language, because we did not understand each other. I had never considered up until that point that patients would be automatically put into a coma for days to weeks just because they had a breathing tube. So to understand why we were having that conversation, why there was this dichotomy between my perspective and her perspective, we have to rewind 50 plus years into the history of critical care medicine to understand why they could not understand what I was talking about. In the 1970s, patients that were intubated and on ventilators were oftentimes awake and walking. Standardized medically induced comas were not a thing, but understand that these patients were not as sick as the patients we have now. These were very different kinds of patients. If patients became sicker, they would die. Medicine and technology had not advanced to care for sicker patients. But again, this was pretty normal to have patients awake, communicative, and even mobile while they had a breathing tube and getting support from a ventilator to do the work of breathing. In the 1990s, we were having advancements. We started to have the diagnosis of acute respiratory distress syndrome. So patient lungs that had some sort of insult, had inflammatory response and filled up with fluid before would have just automatically died. Now in the 1990s, they started to experiment with how to treat those lungs and that exact diagnosis of ARDS. The belief at the time was in order to inflate these lungs that were full of fluid and really stiff, we had to give a large volume of air or pressure, oxygen into those sick lungs. So we were giving 12 milliliters per kilogram, and we were giving lots of pressure, high peeps, and we had stiff endotracheal tubes, and we had these machines as ventilators that now we can't even imagine using. But these machines did not have the capacity to sense patients' breaths, customize the settings and the level of support and timing of the breathing to a patient's own breaths. It was just slam air in, pull it out. So all these things combined set up this really terrible situation in which patients obviously could not tolerate being awake and being trying to breathe with a ventilator. If you can imagine, with those high levels of volume that we were giving patients, we were popping holes in the lungs. Patients were getting pneumothoraxes for frequently multiple times. And so this really was not an optimal situation in which patients, again, could be awake. Now we have much more sophisticated ventilators. We've also learned, we looked back at the outcomes of those patients that were getting that kind of ventilator settings with the high volumes. We saw that that was actually very lethal. We saw that when patients received 4 to 6 milliliters per kilogram, their outcomes were better. And so we changed how we managed the ventilator. We changed the ventilator technology. The breathing tubes were softer, more pliable. Like, all these circumstances changed. But because in the 1990s, we started giving patients the same medications from the operating room, benzodiazepines, opioids, barbiturates, paralytics, thanks to make them stop trying to breathe against the ventilator, we noticed that they looked much better. Immediately, we noticed that their oxygen saturations went up. We also noticed that their eyes were closed and they were still, and they weren't moving. They seemed comfortable, pain-free, and especially it seemed to be that they were sleeping. And this belief that patients were sleeping and that this was more humane and comfortable and essential for patients started to spread not just for patients with ARDS, but patients that were on the ventilator for any kind of reason. And really, it spread like a wildfire throughout the critical care community. And this drastically changed our culture and our practices. It became, over a few years, very standardized and automatic to have kind of a conveyor belt approach of intubate, sedate. And we didn't know really what the repercussions of that were. We didn't have the research that we have now to show that these are high-risk medications, especially for prolonged periods of time. We knew that in the OR, people had amnesia. They didn't experience anything during surgery, so it must be the same for patients that are sedated and intubated for a few days to weeks. But there is a large difference between their experience for a few hours versus a few days to weeks. But even in the late 1990s, people were starting to get concerned about this change in culture and practices. This is a Dr. Petty who wrote to the Chest Journal in 1998, and he said, again, previously my patients were awake, they were human, they were communicating, they were mobile, and he said, but what I see these days are paralyzed, sedated patients lying without motion, appearing to be dead, except for the monitors that tell me otherwise. But these were lone voices. The rest of the community had quickly begun to forget what it was like to humanize care, what it was like to have patients involved in their course. And again, they deeply believed that this was more humane for patients. What they didn't have then, like we have now, is feedback from those survivors. This is what many survivors actually experienced during their medically induced comas. And this QR coded to an episode with this survivor.
They were terrible. The delirium, and I'm sure that was from those strong drugs. I was laying there and I couldn't move, and I felt like I was pinned down, but I knew I was in the hospital bed, and I could see babies floating all around me, and there was a fire around me, and I couldn't help these babies, and it was the most terrifying feeling in the world to be laying there. There's a fire, and I'm worried about these babies. I can't get to them, and they're going to die. And it was horrible. I mean, it was traumatic.
What we didn't know about these sedatives is that they are toxic to the brain and to the body. They disrupt the brain activity so much that patients cannot sleep. So we know that patients that are tortured by sleep deprivation start to have hallucinations. They develop what we call delirium. This delirium is acute brain failure. It's disruption and damage to the brain. They also disrupt the muscles of the body. Patients quickly atrophy.
They were terrible.
And so we didn't know, like we do now, that these medications come at a high price, and it quickly became assumed that they were essential. What we didn't know, again, was that these are life-altering damages and changes to these survivors.
Sedation is not sleep.
It's sleep deprivation.
Delirium is not just confusion. It's definitely not pleasantly confused.
Perceived reality that doesn't go away like a dream.
Sedation means deep trauma.
Psychological pain. Terror.
It's not knowing your wife and assuming she's an imposter seeking to do harm to you with the help of medical staff. Perceived sexual abuse for what are normal medical procedures. A perceived reality that can only be described as hell.
The damage of delirium stays with us long after we leave your ICU. Depression, anxiety, cognitive impairments.
It changes your relationships, changes how you identify yourself, identify with your body. Every relationship that you have will all be forever changed.
Loss of life we knew before.
Loss of self-confidence.
Sedation is not funny content for memes.
It did not spare me the trauma.
They had to resume sedation during that awakening trial, and obviously that locked me back into the terror of being sedated.
Let me communicate with my family.
Please, let me get out of bed. Let your patients get out of bed.
I would prefer any real experience to the unreal experiences that I have and what I experienced ICU, delirium.
We come out of sedation thrashing because of the rat race of horror sedation has caused.
Before you automatically sedate us, make sure it is absolutely necessary.
This delirium day, let's not just bring awareness.
Let's bring change
for millions of ICU patients to come.
Now, again, this is going to tie back into simulation training, but we have to be really clear about the cost of our current normal practices in the ICU. Patients with delirium are twice as likely to die during that hospital admission. And even 6 months after discharge, their chances of dying are 3 times higher. For every 1 day that a patient suffers delirium, there's a 10% increased risk of death. So when we give sedatives to patients that are already having infections and sleep disruptions and things that are making them at risk of this delirium, we destine them to have higher risks of death. And again, this doesn't just impact their time in the ICU, it haunts them for the rest of their lives. This brain injury from the delirium increases their risk of long-term cognitive impairments that we're calling a post-ICU dementia by 120 times. The cognition scores of these delirium survivors are very similar, if not the exact same, to mild Alzheimer's and moderate traumatic brain injuries. So I call this a sedation-induced brain injury. And while these patients are suffering delirium, even if they're not necessarily having traumatic experiences under sedation, they are quickly losing their muscles, which are essential to survival. So when they have this massive muscle loss and dysfunction, they develop what we call ICU-acquired weakness. And when that happens, for example, in septic patients, they spend 20 days longer on the ventilator because they have to rebuild those muscles that are essential for breathing. They lose their diaphragm strength and function, all their other respiratory muscles. So even, for example, our COVID patients, once their lungs had healed from the COVID infection, they had not used those muscles and they had been getting sedatives that are toxic to those muscles for weeks, days to weeks. They were unable to breathe without the ventilator, so many ended up with tracheostomies and had to go to rehabilitation to then rebuild those muscles for breathing, as well as sitting, standing, walking. And when this happens, when they develop ICU-acquired weakness, they are 43% more likely to be dead in the following 2 years after discharge. This is what ICU-acquired weakness can look like. This was probably a very functional person prior to their ICU stay. I'm not sure why they were admitted, but usually it's for one problem, maybe pneumonia, maybe COVID. It's one single problem, and they end up leaving with a brain injury and a neuromuscular condition. So when patients are deeply sedated, it doubles the risk of mortality in the ICU, increases risk of death even after discharge. Delirium, ICU-acquired weakness, it is an independent predictor of these things. So if I, as a healthy 34-year-old, were to go into a medically induced coma for the next 2 weeks, I would likely have all of these complications, even without initial critical illness. So then how can we protect our patients from the risks of sedation and immobility? This survivor, I shared her audio clip. I invite you to listen to her podcast episode. She's had ARDS 3 times. The first time she had the very traditional conveyor belt approach of intubate, sedate, immobilize, lost all her muscles, had terrible rehabilitation, terrible PTSD from that. She somehow had the intuition to go to an attorney after that, once she was well enough to get there, and had documents drafted protecting her against medically induced comas. She said in her declaration that she was only to be sedated if it was absolutely essential for her survival. So the next 2 times that she had ARDS, she was not sedated. She was awake, and here you can see she's texting on her phone. She said in her podcast episode, "I'm not afraid of sedation, or I'm not afraid of the ventilator. I'm not afraid of ARDS. I am terrified of sedation. Sedation is what she's afraid of." So how do we make this transition? We do that, we build and create awake and walking ICUs through the vehicle of the ABCDEF Bundle and the pathway of ICU liberation. Now, the ABCDEF Bundle is a toolkit, not necessarily a strict systematic protocol, but it is a toolkit of elements that help us manage patients to prevent and treat ICU delirium and ICU-acquired weakness. These elements or tools include assessing, preventing, and managing pain, both spontaneous awakening and breathing trials, choice of analgesia and sedation, so choosing whether or not to sedate a patient, which sedative to use, how deeply to sedate patients, delirium assessment and prevention, early mobility, and family engagement. And the goal of that bundle is to produce patients who are more awake, cognitively engaged, and physically active to facilitate patient autonomy and the ability to express unmet physical, emotional, and spiritual needs. Now, each patient is different, right? So this is why this is not a very set, clear algorithm for every patient. It is a bundle, it is a toolkit to help us understand how we can customize care to meet this goal, which may look different and the time may be different for each patient. And so each ICU seems to have a different understanding of what the bundle is. When I share, for example, on social media, I took a survey amongst about 200 ICU clinicians, and I asked them, does your team practice the ABCDEF bundle? 83% said yes, absolutely. Then I went on to clarify, the goal of the bundle is to have patients be awake, autonomous, engaged, communicative, and mobile. Then I circled back and I said, now that you understand what the bundle really is, does your team practice the ABCDEF bundle? That 83% yes turned to 13%. So a lot of our teams don't really understand what the bundle is. And this is really demonstrated by a study that was published in 2019. The bundle really came out in the 2010, or like about 2014, 2016. The Society of Critical Care Medicine rolled this out in 68 facilities, and they tracked how well this went in over 15,000 patients. And I saw throughout that study that there was a spectrum of compliance. Because this is a new approach, the standard approach was to automatically deeply sedate everyone. And so some teams were still doing that, but maybe they were turning sedation off and trying to turn the ventilator off and have patients take their own breaths. And then some teams were maybe doing that every single day right after they were intubated. Other teams maybe were lightening sedation and still doing those awakening and breathing trials. Some teams weren't maybe sedating their patients. And then there's the full spectrum, the 100% compliance, which is everyone's awake and doing their maximum mobility unless there's a contraindication. So we saw, again, a huge spectrum within those 15,000 patients and 68 facilities. The 100% compliance with the bundle was only at 8%. Only 12% of all of those patients were actually out of bed bearing weight. Nonetheless, those even smaller adjustments that were made compared to automatic deep sedation without any breaks, they found that 7-day mortality decreased by 68%. Coma and delirium decreased by 25 to 50%. Physical restraint use, so patients being tied down in bed, decreased by 60%. Mechanical ventilation, the use and duration decreased. ICU readmission decreased by 46%. Patients were 36% more likely to go home. And I noticed that these outcomes were dose dependent. So those numbers I just shared were an average throughout this spectrum. But they found that the closer care got to an awakened walking approach, the less sedation was used, the more patients were immobilized, the better their outcomes were, the more likely they were to survive and thrive during and after the ICU. So this was a huge study that showed that we now have so many more tools and knowledge about how to help patients, again, survive and thrive. But how are we doing now? You'd think with that kind of study, these kind of outcomes, these kind of tools available to us, that care in the ICU throughout the entire ICU community would have drastically transformed. Though there were baby steps of progress made during the 2010s, some teams were more progressed than others. COVID really caused most of our ICUs to regress. There was a lot of fear, staffing crisis, you had really sick patients, ARDS, drug shortages, things that all accumulated and caused us to go back to a lot of the practices that we had started in the 1990s. Though we knew better, though we had research showing that those things are lethal, that is what we ended up doing for a lot of our COVID patients. A lot of our seasoned clinicians that had helped roll the ABCDEF bundle out, we lost them. They either retired or they got burnt out, they left. New clinicians came in, and they came into this kind of environment, culture, and practices. So for many now, this is all I know. We are back to very, very much of what we were doing in the 1990s and early 2000s. I had a nursing student go out and do a little survey, and she compared what RASS score, which is a scale used to measure the depth of sedation. So whether or not patients are awake, whether or not they're agitated, or whether or not they respond to voice or to touch. And she said that she compared what was prescribed, what was charted by the nurses, and what was actually happening at the bedside. And she said 52% of those patients were oversedated. So they were maybe charted at responding to voice, but they were actually requiring touch. 62% of those were 2 points away from the RASS score. So again, they were charted at light sedation, which is what many of the order sets are in our computer system now. When physicians order sedation, it's going to come up as light sedation, a RASS of 0 to -2. But the reality is that those RASS scores were not accurate. And I don't think, obviously, nurses are not trying to do false documentation, but they're not accurately assessing and charting that RASS. So patients are actually deeply sedated, which again is an independent predictor of death. Another study from Switzerland, which is, they're not far off from us here in the United States, found that 70% of patients were sedated beyond a RASS score of 0 to -3. So though they were prescribed to be responsive to voice, they required touch to arouse, or they did not arouse to voice or to touch. This is very concerning. And again, this drastically impacts all of their outcomes in and after the ICU. So why are we there? If we have decades of research showing that the harm of these practices, the benefit of the ABCDEF bundle, why are teams not mastering the bundle? Why is this not a priority? I've identified some barriers that prevent us from mastering the bundle, including knowledge, perspective, culture, team dynamics, leadership support, and experience. Many ICU clinicians do not have this perspective. They don't understand that when patients come into the ICU when they have critical illness and acute respiratory failure and they're intubated, if we automatically put them into a medically induced coma with continuous deep sedation, and we immobilize them, meaning they can't even move a muscle, and we set them up for ICU delirium, it has a huge domino effect. They lead to ICU-acquired weakness, and it shoots off into diaphragm dysfunction, prolonged time in the ventilator, ventilator-associated pneumonia, pressure injuries, DVTs. They can't get off the ventilator, they get tracheostomy, they go to LTAC, they suffer, costs are higher, they get a hospital-acquired infection, and they come back to the ICU with sepsis, and they die. They do not have this perspective. They are not provided with this kind of training and education to understand the impact of those interventions. We are indoctrinated in a sense when we come to the ICU of, welcome to the ICU, here's what it is. And there's a big culture behind that. But again, there's a large knowledge gap. So they're not trying to harm patients. They're just not allowed access, or education about these things are not standardized for everyone in the ICU. And because of that knowledge gap, they don't have a perspective of, again, the repercussions of these things. And because they don't understand what patients are actually experiencing, some surveys show that 59 to 77% of ICU clinicians would want to be sedated if they were intubated. That is their personal preference. So they are doing these things truly out of compassion. They really believe that sedation will protect patients from PTSD, from psychological trauma, from pain and things like that, because they do not hear it from survivors. And I think this belief and this perspective is reaffirmed because when we start sedation and we cause delirium within our patients, when you turn that sedation off, patients oftentimes come out thrashing. They're pulling against the restraints. They're trying to self-extubate, and you look in their eyes and you can see the absolute terror in their eyes. And compassionate nurses and all the clinicians do not want their patients to suffer. So when you turn the sedation back on, that activity goes away. Their eyes shut, they calm down. And the belief is, and the perspective is, that we've treated that discomfort. They're unaware of the endotracheal tube. They have no pain. They're peacefully sleeping. And again, this is rooted in that knowledge gap, but that is their perspective. And that perspective guides how they manage patients. And that perspective and the belief that this is so benign, that sedation is unavoidable, absolutely essential, and even beneficial for patients, leads us to even joke about it. And this is not to demonize any clinicians, right? I, as a travel nurse, when I was immersed into this culture of automatic sedation, I went with what was normal. I didn't have this knowledge either. I knew how to keep patients awake and mobile. I didn't know why. So I too started to believe that they were sleeping, that there was no harm to it, and that some of these jokes were actually funny. When we think it's funny, it reaffirms that this is benign, not a big deal, might as well crank up the sedation if a patient moves a finger. Again, this is not because they're trying to hurt patients. This is the culture that is rooted in ignorance, truly. And then on top of that, there's very poor leadership support to make these changes and to practice this evidence-based approach. There's staffing crisis, poor education, training. We have a lot of gaps in our interdisciplinary approaches, lack of equipment. Leadership isn't seeking feedback from bedside clinicians. We're not tracking our data. There's a lot of leadership support that's needed to make this transition and to sustain this kind of approach within the ICU. And all of this plays into the team dynamics. To practice the ABCDEF bundle, it takes every member of the ICU team fulfilling their role, practicing at the top of their license. As it is throughout most teams, we're very siloed. So PT and OT are in charge of mobility. SLP does a swallow eval on the back end. MDs check in and say, did you do an awakening trial? And the nurse says, yep, they failed, but the nurse just turned off sedation. They started to thrash. They turned sedation back on. RT had slipped into the background, turned the ventilator to a mode in which the patient has to take their own breath. They failed. So everyone just says, okay, they failed. And then the patient stays on the ventilator longer. Instead of everyone coming together to say, what are the risk factors for delirium? How do we prevent this? How do we treat this? Why are they still on the ventilator? It takes a lot of collaboration. And when we work in silos and we don't build those interdisciplinary bridges, this approach is absolutely impossible. And it ends up increasing the workload, the burnout, the trauma, the lack of fulfillment in your career for each one of these disciplines. And I would say from an RN perspective, especially for RNs, practicing in Wake and Walking ICU and then going elsewhere as a travel nurse, I felt a huge difference in the level of support, the collaboration I had with other colleagues of the other disciplines, and the amount of joy and fulfillment I had in my career. I actually got so burnt out to a point I considered leaving nursing because I no longer had human connection. I no longer was seeing my patients succeed and walk out the doors and thrive. I saw patients get lots of tracheostomies, become atrophied zombies in the bed, and I missed it. So after 2 years, I went back to the Wake and Walking ICU during my graduate studies. And I immediately was so happy to be with a team that knew how to work collaboratively together, and watching patients actually succeed, get off the ventilator and walk out the doors, revived my passion for nursing again. And then teams need the experience. They need to experience what it's like to dance with a patient down the hall.
Oh yeah, work it.
We got a whole new thing going on here.
I think sometimes we, from higher ups, we might say, okay, there are huge financial benefits of this. We want our hospital to save millions of dollars with the ABCDEF bundle, which is absolutely what happens. But a lot of times these leaders will say, well, just go and do it. PTs, OTs, you know how to move patients and just do it. But they don't have the training and the experience to feel comfortable doing it or do it safely. They also don't have the experience that leads them to understand that this is safe and feasible and beneficial. So they really have nothing to outweigh their fears about it. They don't know how to do it, and they don't know why they're supposed to do it. And we provide experience before using real patients in so many other contexts, right? We do simulation training for ACLS. When it's a group effort and everyone has their own roles, we're practicing those roles, we're talking through it. We're building up that competency and that experience in a safe environment. But we do not provide that for the ABCDEF bundle. So we're expecting our clinicians to go from a very almost mindless conveyor belt approach of intubate, sedate, coma, trach, peg, to now having patients be awake and having some control in their situation and being variable and having different responses. And we don't know how to work collaboratively as a team because we never have experienced it and we never practiced it. So how do we get there? How do we go from laughing about
what are you talking about? What do you mean? What are you talking about?
Doing everything possible to avoid it and to keep patients as awake, communicative, autonomous, and mobile as possible. How do we get there? That is the question that I've been fighting for years. How do we go from this conveyor belt approach to understanding what the bundle is really about, how to utilize all of these elements as a team to create an awake and walking ICU? That is why I created Dayton ICU Consulting, because it takes a team, takes experts, takes a lot of support and changes to make sure that this is successful and sustainable within each hospital system. So as a company, we go into hospital systems and we do a gap analysis. We try to identify where are they currently at in the bundle? Do they have any kind of foundation? What are their current practices? What are their barriers? What's the culture, the mentality? What's stopping them from succeeding? We do financial pitches to executive leadership team to make sure that they're on board and they're ready to provide support, that they understand that they can spend thousands to then save millions throughout the many years to come. We then provide customized live CEU webinars to lay a foundation of knowledge. It's simulation training can't even happen until each clinician on the team understands why this is important. we can't approach the how until they understand the why. And there's lots of information needed for each different specialty of ICU. Each team has different barriers. Each team has different level of understanding. So we really customize those webinars to make sure that they are, again, appropriate for each team. And they're interdisciplinary. So every member of the ICU is to attend those webinars. And they can be recorded and embedded into their system. It becomes part of their onboarding process for new clinicians. I provide leadership training, engagement, and support. So we're meeting beforehand, trying to figure out where they're at as a leadership, making sure that they're prepared to lead this and support their team in this. Each discipline selects champions from rehab, respiratory therapy, nurses, MDs, APPs, everyone comes to the table and we start preparing their game plan. Then I come on site with someone from rehab, so either a physical therapist or occupational therapist, a respiratory therapist, and myself. We participate in rounds. We evaluate how their team dynamics are, how they discuss and collaborate on these elements of sedation, delirium, and mobility management. We offer suggestions and ideas to optimize their plan of care, and we do simulation training. We do 3 sessions each day that we're there. We stay there for 3 or 4 days, depending on how big the team is. Our goal is to provide that training to every member of the team. Previous efforts of the ABCDEF Bundle rollout have been selecting a few champions, giving them a day or 2 of some training, then telling them to go and convert their colleagues. And understanding how difficult these barriers are, how deep this culture and the roots of this are, that is just obviously has not been successful. So providing each member of the team the opportunity to ask questions, to practice, to collaborate, to apply the principles of the webinars is what has made all the difference in the teams that we have trained. So we do 2 sessions during the day, 1 session at night shift. A lot of times night shift is left out of this, but they have a lot of influence in the sedation practices and what happens during the day as well. And then we follow up with those champions during champion meetings for the next 6 months to make sure that they are continuing to progress and master what they have learned. When we do simulation training, we have many objectives. We want them to, again, apply the information from the webinars. We want them to practice critically thinking through sedation management, whether or not there's an indication for sedation, what the risk factors for delirium are, if they have delirium, how to mobilize patients, how to prepare for mobility. We want to make sure they know how to accurately assess for delirium and sedation. And we clarify and practice the roles between all of the disciplines in the ICU. They practice collaborating. We practice how to utilize the families and how to engage families, how to talk to the patients, how to engage them in that process. They're preparing for mobility, screening for mobility, navigating the different equipment that they have available on their team. And then we ask them for feedback so that we understand what their feelings and thoughts and concerns and ideas are. Now, I would love to provide a training manual, a step-by-step algorithm, and just email it to every leader in every hospital and say, just do this, and this is going to work for every team. But having done this a few hundred times, I will say honestly, sometimes and oftentimes, going into simulation training, coming on site is like stepping into a lion's den. And this is not to make any of the clinicians look bad, but there is a lot of hesitation. There's a lot of incredulous clinicians that are not excited about this approach because change is hard. This is a very different approach. And if it's very clear who has or who has not listened to the webinars, if they have not listened to the webinars, they have no idea what this is about, what it is for. And sometimes those are the most important people to train because they're not the ones that are going to easily jump into a webinar. So we have to understand what that hesitation is rooted in. Many have a lot of fear. There's a myth throughout the community that early mobility is high risk. We know throughout over 14,000 documented mobility sessions that the adverse event rate is 0.6%. It's actually extremely safe when we do it correctly, but people are very afraid. As they practice, as they have a chance to express those fears and have them addressed, that starts to dissipate. They have doubts. They don't understand. They don't think it's possible for their patients or feasible in their team. They have a lot of pride. I mean, and I think there's a lot of reasons to be proud. A lot of these clinicians have sometimes decades of vast experience. So it's hard to be told a new approach or even to accept that what they've been doing may actually be causing patients harm. There's a lot of trauma from COVID. There's, again, a knowledge gap. So bringing in experts into a simulation training environment in which I can take the heat. They can tell us what their issues are with this process. They can say things to us as an objective outside party that they may not be able to say comfortably to their leadership. Allows them to work through these different issues and then focus on actually doing the training and actually getting it done. So I bring in experts from all over the country of different disciplines. So again, I bring someone from rehab. I have occupational therapists and physical therapists from all sorts of specialties with vast experiences, respiratory therapists from different hospitals. It's nice to have these different approaches to come in and say, well, in our hospital, we tried this hospital, we did this. Again, because every team is different, every specialty is different. And so we bring in lots of different experiences and insights to make this a really productive experience for the teams that we're training. So they come into either a Sims lab or to an extra room on the ICU. There are pros and cons to both approaches. I love the Sims labs because it's obviously very quiet. It's a consecrated area for learning. In an ICU room, it's also a normal environment for them. They can see and practice navigating the different equipment and tools and patient within their own space, right? Many old hospitals do not have as much space as this Sims lab. So they get to practice how to safely move the equipment when there's not so much room. It's also really important for them to quickly be able to come to simulation training. Sims lab might require people to come on their days off and things like that. That can create a barrier to making this accessible to all the clinicians on a team. And so someone pretends to be the patient. It's either a member of my team or a member of their team. In this picture, we have a physician and an intensivist pretending to be the patient, which I actually love when that gets to happen because it's so unifying for the team. It's very humbling. They really get to see that their physicians, their leaders are really invested in this process. And it's just really good team building. And oftentimes I create case studies based off of their own patients. So we'll have their champions scout out patients that have already been in their ICU, whether things went well or things didn't go well. We use them as an example because then they can't say, well, not our patients have these exceptions or this isn't realistic for our ICU. We're talking about their own real patients and we're critically thinking through how to navigate their care. And so a lot of this is obviously hands-on practice, but a lot of it's discussion as well. I'm asking open-ended questions like, what are your concerns for this patient? What are the risk factors for delirium and ice-acquired weakness? How would delirium and ice-acquired weakness impact this patient's life? So we're helping them zoom out and look at what kind of function did they have before? What was their career? What were their family dynamics? And what do we want to work towards now to return them to after the ICU? That's a perspective that is very new to our ICU teams. And asking questions like, do they have an indication for sedation? Making the teams think through, is mechanical ventilation, is a ventilator and a breathing tube an automatic indication to be in a medically induced coma? How will it impact your job and team if they develop delirium and ice-acquired weakness? What is their RAS? How deeply are they sedated? We're teaching all the disciplines how to assess for that level of arousal or level of sedation so that everyone can speak the same language. So we go through a lot of these critical thinking questions and allowing everyone from each discipline to answer, be heard, to discuss. A lot of times they're saying, yeah, but what if they do this? What if they come out and they're thrashing? What if they're trying to self-extubate? And so it takes a very trained team of facilitators to respond to those questions, to go along with those scenarios. Okay, let's say that they do come out thrashing. What are you going to do? Here are some ideas. So it's again, not just it's different from ACLS training. There's not just a very clear-cut algorithm, but we're teaching critical thinking and collaboration so that they will be prepared to adjust their approach for each patient and prioritize preventing and treating delirium and ice-acquired weakness. And some of the benefits that come from this is they have a safe environment to ask questions, share doubts, and identify gaps. They, again, have never really had this opportunity to stand shoulder to shoulder with respiratory therapists, physical therapists, occupational therapists, physicians, APPs, and to talk about what they need from their colleagues, to share what is making their job hard, what kind of support they need, ideas or preferences. They just finally get to figure out as a team how they're going to get this done now that they understand what they're working towards. It's a risk-free opportunity to practice mobilizing patients using real equipment in their own room. It's scary to try something you've never done before on a real patient. No one wants to be fumbling around with a real patient. No one wants to cause a patient harm. So they get to think through the logistics of this equipment and these high acuities without having to take any risks with real patients. They build their teams, they figure out how to discern and master their own roles. They start to engage and answer questions and apply information to patient care. So what I love is people that come into simulation training, and you can tell in their body language, they probably haven't heard the webinars. They're probably being forced and shoved into the simulation training, and they're not excited about it. I mean, I will hear things by some people, let's just get this over with. And I embrace it. And I say, yeah, let's just do it. But you can see that they're not engaged. They're not excited. People that have listened to the webinars are actually, you can tell they know what they're working towards. They're excited. They might have some fears and hesitations, but they're at least open. Some people are absolutely not open. And throughout this process, you can see their body language start to change. They start to answer questions. They see their colleagues jumping and doing things. We're laughing and joking together, and they change. And by the end, they're asking more questions. You can tell that they're seeing the picture. I had a nurse come observe a simulation training in a surgical ICU. And when I saw him, he looked like a stereotypical trauma nurse. I don't know exactly how to describe that stereotype, but he just seemed tough. You could tell he was very experienced, very knowledgeable, very confident. And you could tell that he was not buying in when he first poked his head in. He was ready for a fight. And then again, I saw that body language changed, and he pulled me aside afterward and he said, I had a lot of words for and about you before you came on site. And I laughed and I said, yeah, I'm sure you did. And he said, but now doing that, I get it. I see it. This is so cool. The next time I visited and I trained his team, he pulled me again to the side and said, hey, are you hiring? So it's really fun to see these people that really would be hard to convert if it was just their own nurse manager or medical director trying to shove them into this, allowing them the space to explore and understand what we're working towards and feel confident in their teammates to be able to provide this kind of care. So those lions quickly become some of the kindest and most open and even leaders of this process. And I tell leadership that when they get worried, they're like, I don't think they'll ever buy into this. And I say, just give it some time. Give them a chance, because I've seen the most hesitant, resistant naysayers end up becoming the most passionate pioneers of this process. And so I've seen lots of benefits that quickly happen throughout the next week or two. This is a process of evolution following our visit and as we continue to support them, but they quickly start to talk about these things in handoffs, in rounds. They're responding to agitation without sedation. They're quickly seeing a decrease in length of stay. They're showering their intubated patients, which I don't even train them to do. They just start getting creative in the process of care. They're having fun. This is a letter that one nurse manager sent me, and I'm just going to share some of the highlights. She said, everyone's taking initiative to ambulate a patient. She doesn't have to be there every single time. If a patient is sedated, there's a good reason why. Nurses are saying, Andrea, I love this. This is so much easier. People are amazed when they walk around our unit and every patient is up in a chair and awake on the ventilator. They come on to day shift, and night shift has already gotten patients that are intubated on ventilators up into the chair because they're doing this right away. Patients are strong. It doesn't take so many people. They're excited. They're just feeling passionate about it, and they're really giving patients their voices back during their critical illness. Other teams have been able to report their some of their outcomes. So one hospital invested less than $100,000. Again, that was not all to me, but they reported a very conservative estimate within the first year before they even had this mastered of $1.2 million. Another team reported 1.5 day decrease in length of stay, even within the first 9 months, again, before they had this mastered. So teams need a lot of support to overcome deeply rooted cultural knowledge, hierarchical barriers within their ICU teams. But when we help them overcome these barriers, especially during simulation training, they can become awake and walking ICUs. We can help patients survive and thrive, and they can find joy in their careers again, as well as drastically decrease healthcare costs. And I'm happy to answer any questions about this. Jennifer Sanchez says, I think this is beautiful, seeing a patient move, walk, and thrive. How do we do this in an ICU unit in which there is a passing happening, coding, those who do not have a good outcome, and having family members who are grieving, watching others walk around with music on. Again, I praise this amazing work. I'm just thinking for other families in the same unit. Yeah, that's a really, really important thought, Jennifer. Thank you. I do know that I hear from families that it's really hard for them to walk on a unit in which patients already seem to be dead in the bed. You know, they can kind of see patients. We try to be as private as possible, but they can already see patients just laying there. I think for most people, they like seeing hope and optimism and life throughout the ICU. And I have never gotten the sense that this exacerbates their grief or makes them bitter to see other people succeeding and fighting for their lives. I also think that there is a sense of we did everything possible. We don't have to wonder, even as clinicians, we don't have to wonder, did they die because of the sedation? Could they have had better outcomes if they've been awake and mobile and prevented these other complications? There's also something so beautiful when patients are cognitively intact and they're able to write, they're able to text, and they're able to say their goodbyes. I've had many patients still be so intact that they're able to say, I'm done. I don't want to continue these life prolonging measures. Or we can tell them honestly, it's time. We've done everything. You've worked so hard, but it is time. Who do you want to be there? And I ask them, what kind of music do you want? What do you want to, a lot of times they request things like a Slurpee from 7-Eleven as their last sip before they pass. Being able to humanize and customize even the dying process brings families and patients so much comfort. What I think is even more traumatizing is when they don't get to say goodbye, or when families have to wonder if this was what their loved one wanted, if that was the right choice. Leaving the families with all of that burden is extremely traumatizing. So I'm not sure, maybe some might feel a little bit bitter by seeing other people thriving, but I think there's a lot more opportunities to bring comfort through this approach. Adina says, other than the CAM ICU, is there anything else that is consistently used in the ICU level to measure delirium cognition? Is there a tool assessment that is often utilized for measuring and tracking early mobility with therapy? So with the delirium, there is the ICD scale. So there are 2 validated screening tools to test for delirium: CAM ICU and ICD. CAM ICU is what most of our teams have. And that's probably the most user-friendly. I don't have a lot of experience with the ICD test. Someday down the road, we'll have maybe some serum lab markers. That would be really nice. There's some developments happening for like a low technology, simple EEG monitoring, like stickers on the forehead that monitor brain activity. Again, this is still in their very early stages of development, so maybe someday, but right now the only way to screen for delirium is through those manual tests of usually the CAM ICU. And to measure mobility, that is often a really difficult challenge. We have so many different, this could be a whole discussion on its own. We have things like the BMAT, the Johns Hopkins. There's just not a perfect screening and measurement tool for mobility in the ICU. So with teams that I work with, we really try to figure out ways to make it so that we are very accurate in reporting. Because to me, as a nurse practitioner, it makes all the difference if someone's walking 300 feet yesterday and now they're only able to walk 5 feet. I need to know that, not just that they were walking or out of bed, but I need to know how far they were walking because it tells me something changed in their status. So usually right now, documentation and tracking is very imperfect, but we can at least use some of these basic tools to measure their general level of mobility. And I think there needs to be higher documentation in addition to that to show more specifically if they were standing, how long did they stand, how long did they sit, things like that. So some of this is a little bit more manual documentation. I think our EHRs have ways to catch up with some of our more progressive cultures. Arthur says, beautiful presentation. Thank you so much. My question is, what do you think are key factors in implementing the ABCDEF bundle in an ICU? Some of them you already mentioned, but maybe you could summarize it all. I think key factors that are needed in every ICU that are often missed are a deep understanding of the why. Clinicians have to hear it from survivors. They have to understand the research, and then they have to have a very streamlined way to learn the how. So we have to change some of our perceptions. For example, awakening trials are seen oftentimes as a back end thing. So once ventilator settings are minimal, when patients should be getting off the ventilator, now we're going to take sedation off. And if they don't meet criteria for breathing trials or a past breathing trial, then we turn sedation back on. So things like that, we really have to almost scrap our previous understanding of the ABCDEF bundle and rebuild what we're working towards. So that can be a challenge. So if teams say, yeah, we practice the bundle, but then I go in and I look through their data and their charting and see what they're doing. Sometimes it's easier to just almost start from the ground zero and say, please forget everything you ever learned about the bundle. And let's talk about what actually happens to patients, what they're telling us, what the research shows, and then what do these tools actually mean and how do you actually implement them and customize this for each patient? So I think that's probably a good foundation to lay for key factors in implementing the ABCDEF bundle. Sometimes we underestimate the power of knowing the why and the impact that has in each team being able to find their how. Chelsea says, beautiful seminar. Oh, I missed Chelsea's comment. Seminar, such an important topic. I was wondering if it is possible to get a copy of the seminar or access to resources to share with my peers. Yes, you're welcome to, this QR code goes to my website if you want to email me, or you can even set up a free consultation meeting. I'm happy to talk about where your team is at, what your barriers are, give you ideas on how to start, ways to approach your leadership team about this. I will fly out to any hospital, do a free gap analysis. I will do a financial presentation for your executive leadership team. I appreciate how hard this is to get buy-in from your clinical leaders and your higher CEOs, CFOs, CMOs. So I come prepared. So let me know how I can support you in that. I know that's a daunting task, but I have some experience in getting this done. Any other questions? Again, feel free to reach out. I'm happy to answer any further questions, even as you think. I have the podcast, Walking Home from the ICU, for clinicians on my website, Dayton ICU Consulting. Those podcast episodes are under the podcast tab, and they can be organized by topic. There are categories. So if you're looking for survivor testimonials of delirium, or you're looking for clinicians that have practiced in an awake and walking ICU, different principles, it's organized by topics. And there's a lot of information. There are transcripts and citations, so you can go dig into the research yourself. Again, I'm happy to answer any questions anytime.
Awesome. Thank you so much, Kaylee. And we appreciate everyone's participation today. Okay. I am going to go ahead and just close down the poll. And again, thank you everyone for coming today. So you will be hearing from us. You will be able to receive a recording of this, and just keep your eye out in your inbox for that. So, and Kaylee is going to go ahead and just share this video a little bit more about her consulting services. So.
you.